Welcome to Variations 4. This is the hematology unit. In this video, we're going to be covering questions 12 to 14. Quick overview of hemophilia, neutropenia, and leukemia. So question 12. What is the deal with these three kinds of factor or protein deficits called hemophilia A, von Willebrand, and hemophilia B? What are their effect on platelets, PTT, and overall, what are we doing here with them? So let's look at map 7 to answer all those questions at once. Hemophilia A, your deficient factor is factor 8. So obviously what you're going to want to do to deal with that is give factor 8. Von Willebrand disease, you're missing a coagulation protein, which they have labeled the VWF protein. Hemophilia B, you're missing the factor 9 deficiency. Okay, so I mean, if you look at these in general, all of them have the same kind of problem if they don't happen all at once. They're separate things usually, but if any one of them happens, then well, the middle one's usually quite mild, as it says here. But in general, you've got an increased bleeding risk. Bleeding time is prolonged. What exactly do we mean by that? Well, INR and PT that pathway is not affected. For hemophilia A and hemophilia B, platelets themselves are not affected. Von Willebrand is the one that affects the platelets in terms of the platelets being structurally defective. So platelets are defective in von Willebrand disease, and that is how they are contributing. One way it contributes to bleeding. Platelets are not affected in hemophilia A and B. That being said, as we know, platelets play a role in coagulation, so we can safely say that all three of the problems, all three of the diseases above, increase PTT. So bleeding time, coagulation pathway, PTT, therefore bleeding time, is increased for all three. So these patients are at risk for bleeding. So I went to school, for example, in much younger years, like I'm talking grade school here. There was a boy in the class who had hemophilia. I don't know if it was A or B. But the point is, he got punched in the nose once on the school ground, and his nose bled and bled and bled. And I mean, as a boy going to school, getting in scraps, every kid does it, you know, typically once or twice at least. Everyone's had a nosebleed. Nosebleeds stop, you know, usually pinch your nose, it stops. This kid wouldn't stop bleeding. He got sent home. He may have actually gone to the hospital. And later on, the teacher sat us down and said, he has hemophilia. I don't know if she used those exact words. We were very young. But she explained that he has a problem stopping to bleed. So that we had to actually treat this person a little differently. You know, shouldn't be fighting at all. But he had increased PTT. And so would bleed and bleed and bleed. Which kind of explains these sequence of events that could happen with any one of them. Okay, down here. So what are you doing here? You're either giving well, preventative care. First of all, these people need, like I just said, they have to be careful. They probably don't want to play hockey or football, for example. If there's been serious hemorrhage and replacing blood loss, replacing blood clotting factors. Although fresh frozen plasma is rarely used, what we usually do is give desmopressin, PO, IV, or nasal. I've seen lots of patients take it nasally. That stimulates factor 8 growth. It also stimulates VWF production. They might need to take some antifibrinolytics to enhance the clot stability. So, but that could cause its own problems too. So that's an interesting point to keep in mind. It could cause, you know, increased chance of clotting that you don't want. So, I mean, it really depends. But it's a possibility that you might take these meds too. And obviously they'll need factor 9 if that's their issue as well. And you can check your med guides and Google what route that's given in. I haven't given that one very often. I've given factor 8 via IV. I've also seen a lot of patients take, desmopressin nasally for, I haven't seen any patients with VWF, but they could, but typically it's for factor 8 that I've seen. Okay, so the next question here is question number 13. What constitutes neutropenia? What constitutes neutropenia? So just looking at map number 8 here to address question 13 on neutropenia. So neutropenia depends on where you're at, what facility you're at. There might be a slight change in definition of what number signifies neutropenia, but generally, I mean, here's your normal range of neutrophil counts. Neutropenia is generally viewed as being less than 1, or again, in some facilities, less than 1.5. Okay, so if you see someone with a neutrophil count of, say, let's just be conservative here. If you see someone with a neutrophil count of 1.5 or lower, times 10 to the 9, of course, then they are neutropenic. And they are at great risk for serious infection. Of course, the worst of those being they're at great risk for sepsis. Lots of things can cause it. There's a whole list of causes. Some common things that we come across are immunosuppressants, but probably the biggest one I've come across in medicine is chemotherapy. Chemotherapy causes death too. Kind of causes that pancytopenia, really suppressing the white blood cells, neutrophils. We really see a lot of neutropenic patients once they've had chemo. So neutropenia, the problem, there's lots of problems. Chance for great infection risk and sepsis, we've already said that. If you're looking at a wound, this is as an example, say you've got a wound that's infected, you'd think in most cases for a non-neutropenic patient, that would be really obvious. You'd see the redness, you'd see the swelling, you'd see the pussiness, the pain, all that kind of thing, the odor. You're not going to see a normal immune response with someone who's neutropenic. So you might not see any of those symptoms. So it's a problem. Diagnosing infection can be a little more difficult. That's why one of the most important vital signs for a neutropenic patient is temperature. We see temperature spikes or even temperatures higher than our normal range. We are really going to start doing some workups and getting some specimens to check, is the sputum, is there infection there? Is the catheter, have they got a UTI? What's going on here? Do we need a wound culture? Do we need to do a blood CNS to check for sepsis already? And we might see other vital signs changes too if there's sepsis. So vital signs become really important for neutropenic patients, especially temperature. Now you've covered or you will cover if you haven't already, in INP, in the infection controlled lab, you're going to talk about what you do in a neutropenic room in terms of reverse isolation, in terms of protecting the patient. And here's a short list here that is very similar to what we talk about in the INP. This very short list though. All of the isolation you're doing here and all of the gowning and gloving you're doing here is to protect the patient. Positive pressure room is a room that pushes air outside the room. So for example, if someone coughs outside the room, that debris, sputum debris is pushed out the room and not sucked in or allowed to enter. The door should be closed though. So yes, a rise in temperature above 37.4, you want to start contacting the team. You're above 38 for this patient, you're definitely going to be doing some blood cultures at the very minimum. So there are meds you can give, like filgrastim. That's I believe that's a trade name. That will inhibit growth of neutrophils. But I mean, it's not going to work overnight. And the reality is that these guys are going to be neutropenic for a while. Okay, and I think we're on the last question of this section, which is 14, which is asking us to explain leukemia. So question 14 is just asking us to do a quick overview of leukemia and how that can lead to basically what's called pancytopenia, which is a decrease in each red blood cells, platelets, and white blood cells. So let's look at map 9 and get a sense of what's going on here with leukemia. So in essence, what you've got is too many white blood cells. Now, the problem as well with these white blood cells is not only is it too many, but they are dysfunctional. So they don't really do their job too well. So ironically, although you have an increase in white blood cells, the patient's still at risk of infection because these white blood cells are dysfunctional. They are what they call immature, and they don't do their job well. The other problem is that with the increased proliferation of these white blood cells in the bone marrow is overcrowded and unable to produce adequate amounts of, well, functional white blood cells we already know is part of the problem, but it can't produce adequate amounts of platelets or red blood cells. And so you have all of the problems that come with each of these: infection risk, bleeding risk, and signs of anemia. How do you deal with each one of these? Infection risk, bleeding risk, signs of anemia. You look at your previous notes. Obviously, you might do transfusions for anemia. Obviously, you want to assess for bleeding risk. You might need to give products to decrease bleeding risk, whether it's coagulation factors or platelet infusions. White blood cells, the whole reverse isolation thing we talked about above. I mean, you look at each one of these and it's a whole kind of section on its own that we've done some work already talking about each one of these. In terms of what do we do in general, chemotherapy, this is a type of overactive bone marrow here. So we might want to, if we can get a stem cell transplant or a bone marrow transplant, of course, we might need to depress the action of the bone marrow with corticosteroids and chemotherapy. You're going to need IV fluids to flush out the excessive cell debris from these high amounts of white blood cells. You might need to do a leukapheresis, which is that fancy way of getting rid of excessive white blood cells. You got your typical kind of cancer treatments here of the chemotherapy and radiation. Okay.